afternoon. Hope you won't fall asleep listening to my lecture. I'm not a pediatrician, first of all. I'm a public health physician and a microbiologist, but I'm showing something on pediatrics. In fact, I just want to show a comparative study, findings of a comparative study in Bangladesh and Malaysia. The same study we did in Bangladesh 4 or 5 years before, and currently we are doing this one. Of course, not completed. Before I deliver this talk, let me tell you that I'm not going to show any causative association, not causal relationship. I'm just showing the difference we found and some of the socioeconomic factors which attributed to that. This is a whole set of our team in Japan, in Malaysia, in Bangladesh, and in Bangladesh Hospital, Dhaka Medical College Hospital, and in LLC Hospital at Kedah, Malaysia. To start with, you all know that the prevalence of childhood pneumonia is very high, 40 to 50%, and in neonates even more, 80%, with a case fatality rate of 21%. About 11 million people under 5 children die in least developed countries. 30% under 5 children, deaths are attributed to either ARI or pneumonia or both, which we reported 25% from Bangladesh. This has a potential public hazard. Globally, as I said, about 18% of the total 8.89 million child deaths are due to childhood pneumonia. Childhood pneumonia claims more burden combinedly than morbidity of AIDS, malaria, and measles, as much as that. So we undertook that work. Okay, what are the causative agents? We found streptococcus, we found staphylococcus, we found many other things, but what about Hemophilus influenzae? The WHO has started giving Hib vaccination for the last 10 years. And in many countries, it is dropping. But in some of Asian countries like Bangladesh and Malaysia, Hemophilus influenza is really going to create a significance. The common bacterial pathogens we found are Streptococcus, Hemophilus, and Hemophilus influenzae, also causing lower respiratory tract infection, especially type E and F as invasive diseases, and 60% of those were multi-drug resistant. That's what the problem was. And we did this study using a very simple method, Naso-pharyngeal method. I'll show you a slide. It's not an oral swab, it's not an oropharyngeal swab, but it's a nasopharyngeal swab, and you'll have to stick to the posterior wall. I'll show you a slide. Why it is essential to determine the organism? Because often it's too widely distributed and often difficult to find out this causative organism because compounding of very hard effort of differentiating bacterial and viral. Sometimes we cannot. And today, we don't have any ideal test to differentiate that. That's why it is very hard. So, we essentially need to determine the organism because for you people, clinician, pediatrician, for better clinical management, for prompt and rational antibiotics, which is a very big problem in our countries, LDCs. It will help reducing morbidity, hospital stay, and the cost. Plus, it will reduce pneumonia-associated mortality too. The question now arises, what serotype of Hemophilus influenzae are important? Well, every types are important, but Hib was very much high. Nowadays, it is declining as much as 0 or 1%, less than 0.1% in Brazil, in America, some Asian countries, in Japan, but in many other countries, the other serotypes are flaring up. We have lowered down the Hib, but A, D, E, F are coming up. And This non-typable strains replacing Hib has a globally has patent global impact. So we became curious to know if these non-type or Hib pneumonic children, what they harbor, is it very important or not? Raising the ultimate voice. Do we really need a conjugate Hemophilus influenza vaccine to protect our children from pneumonia, as we did for conjugate vaccine against pneumococcus? And with that, I give you some other hints on epidemiology, why Hemophilus influenza or any pneumonia kills children. There are several risk factors, 4 or 5 or more. Poverty, gender, overcrowding, nutrition. These are the 4 or 5 major factors which kills. So the objective of our study was to look at the epidemiology of under 5 pneumonia, assess clinical features and bacteriological characteristics in them, and determine probable risk factors. Specific aim was all those things, and to see if this MDR, multi-drug resistant pattern, correlates or associates with the Hemophilus serotypes. Since I have started telling that it's a comparative scenario between Malaysia and Bangladesh, let me give you a quick profile. This is Bangladesh. You can see in whole Asia, it will be very hard to find out our poor Bangladesh. And in this Dhaka, this is the Dhaka Medical College Hospital where we conducted the study. And this is the scenario of crowdiness in Bangladesh. It is the 8th most populous country in the world. And I didn't take this picture. I took it from World Population Statistics. And in Malaysia, to give a short profile, it has 2 parts. We did this in this peninsula part. This is called Kedah, but we didn't go there. Here in 2 hospitals, I'm going to tell you about 1 hospital. It's an ongoing study, not completed. And before going to show our findings, let me just compare some geographical and social status. According to World Bank latest status, total area is more than 130 million, and Malaysia is just 320. How much? Maybe 4 or 5 times less. Bangladesh is higher than Malaysian. I mean, area is more than Malaysian, and population 160 million and more. 8th most populous is 44th. So much difference. And Bangladesh bears 2.3% of the total population, where it is 0.4. And in the last, the IMR and under 5 mortality rate are higher in Bangladesh, lower in Malaysia. Now, why I'm showing this is, when I will show you some differences, you may think that there are differences, but very interestingly, these differences found to be less than those 4 differences which I meant. That was the patient's method. Under 5 children, we take from Bangladesh, Dhaka Medical Hospital 351, and SB Hospital in Malaysia 148. But the mean is comparable, so don't worry. Study place was Dhaka Medical Hospital and this Ulster Hospital in Malaysia, and laboratory part was done in Institute of Public Health, where I used to work with WHO, and the EMS University, where I'm working now. There's the Dhaka Medical Hospital, and that is the Ulster Hospital. We did systematic random sampling every 3rd under 5 children from OPD, Dhaka Medical, but in Malaysia, we took from OPD and indoor both, and every second one. Using these criteria, any of the 2 major samples, as WHO says, cough, nasal discharge, nasal flaring, fever, difficult breathing, or chest restriction. There's the WHO clinical diagnosis we did in 2 tiers, first by the paramedics and then by the pediatrician specialist, following this WHO chart. This is the diagnosis made by the paramedics and then referred to the pediatrician expert. And then only we go for sampling with informed consent. This is one of my master's thesis student. And this is the study questionnaire we do. This is from Ulster. This is the Japanese team who came to visit our lab and get some training. And then I went into this training. She is one of our co-investigators doing PhD in our university. That is the whole team. This is the thing I was going to tell you. See, we'll have to reach in the posterior wall because Hemophilus influenza is very clever. It resides, or whatever you say, stays in the posterior wall. So with normal swab and tongue depression, you cannot reach there. So this is a specially designed cotton teeth flexible loop from Japan. We used that, and it really worked very good. Quickly transported this to the lab, and in the lab again, there was a training, prior training for 1-2 months from Japan, from our experts. Then only the workers started doing it. The Naso-pharyngeal swab. The growth was done in chocolate agar plate. Nowadays, we have got chocolate agar 2, who are not bacteriologists, you understand. It's more better with some supplements, overnight incubation, oxygen, and then we read the culture plate. This was in Bangladesh, and I'll show some in, oh, no, not here, and some in here. After culture, we did the antimicrobial resistance pattern. Before that, we had some biochemical testing. The problem was, this was done in Bangladesh. This was Japanese NISU-NH rapid test, but in Malaysia, we cannot do that. It's very costly. We are doing it using just conventional conventional test tubes, but about similar. Statistical analysis was done, mostly chi-square. Correlation 1 or 2, I'm not showing now, and reduction a bit. 0.5 was considered as significant with 95% CI. And there's the clinical findings. From Bangladesh, we got pneumonia in 252, severe pneumonia 109, no very severe disease. This is the format for WHO, which Western world and even Malaysia, they don't care. They care about bronchopneumonia, pneumonia, other pneumonia type, all those things. So this shows that there is no significant difference between age and gender of our children. And age specific distribution and this severity was not also associated. But gender was associated in severe pneumonia cases. In Bangladesh, we got severe pneumonia cases according to WHO criteria. Here in Malaysia, they call severe pneumonia when there are 4 or 5 days hospital stay and state was severe and the X-ray says consolidation and all those things. But it is severe pneumonia in both cases. Gender-specific pneumonia cases was not. See, in the severe pneumonia cases, it was significantly deferred, but in pneumonia cases, not deferred because of these social factors. I'll show you later on. If I compare these two, there were so many slides, I just sat down now and cut it down to make it short, because it is a 1-hour lecture, actually. It was meant teaching. Anyway, this is the Bangladeshi data, this is the Malaysian data. See, type of hospital, both are tertiary care and teaching, and it's not half teaching or training, not full teaching like Bangladesh, Dhaka Medical. 140 beds in 6 wards, 120 beds in 4 wards. No pneumonia, severe pneumonia case was diagnosed in Bangladeshi following WHO. Here they do pneumonia and bronchopneumonia. This is the clinician part. That's what I cannot intervene. Total change studies 465 and 148. Because it's ongoing, maybe it will be also 350 or 80 within the next 2 months. Total pneumonia cases was 78% in Bangladesh, but 94% in Malaysia. Why? Because here, ARI cases was included in the OPD, which we excluded later on. But here, all are the cases who were admitted with pneumonia. So only few cases were left, but mostly were pneumonia cases. Mean age was very similar, as I said before, and male-female was also very similar. Pneumonia cases versus gender had no difference among boys and girls in both hospitals, in both countries. Bacterial findings also similar, but it's a very big difference in Hemophilus influenza incidence or prevalence, what do we say. We found 47% Hemophilus influenza. Out of those, 52% was non-typable and 6% was B. I mean, 30% was B. That's the same thing, I'm showing it. But in Malaysia, we got only 9.3%, only 4.8%, only 7 cases. And all the 7 cases was non-typeable. This might be the cause of action of HEB or might be other causes of socioeconomic factors. I'm going to show you why. So we serotyped 9.3% and non-serotyped non-HEB is 8.6%. These are all 0. Non-typeable we got about 18 and they got 7 out of 700%. MDR pattern, multi-drug resistant pattern didn't differ. Most of them were resistant to, in Bangladesh, amoxicillin, cotrimoxazole, and penicillin, here also. Blah, blah, and other is there. I'm not going to do in details. Now, this is my main part. I'm not going, I just gave a run on clinical and bacteriological, but this is the main thing. I deliberately wrote this plausible and gave the bracket risk. We can tell factors are stated because we don't know yet. We didn't do odds ratio and the study is not finished, we cannot compare. Just to show you some hints, some what you call hunch that it might be. Look, colostrum feeding in Bangladesh is very low, but it was highly significant in causing pneumonia. In Malaysia, it's very well developed and cholesterol rejection rate is very low, but still it is about to be significant. That means it's really good. Exclusive breastfeeding in Bangladesh is about 60%, 65%. So it was related to those who didn't do exclusive breastfeeding. They got more pneumonia, their children. But it is also significant here in Malaysia because the exclusive breastfeeding is about 80 to 90%, but not all. Similarly, as I said, parental smoking, early hospitalization, tin roof house, not significant in Malaysia, but in Bangladesh, yes, it does. Cooking indoor fire with charcoal or wood in Bangladesh, highly significant, here nearly significant. Ventilation, about similar in both Bangladesh and here, because in Bangladesh also it's overcrowded. Here also 4 or 5 people live in 1 or 2 rooms. Mid-class people. Hand washing in Bangladesh, I don't believe this data is right anyway, but here this data is very right and it was very significant. Parents and children who used to have their hand washing practice, they had less pneumonia than others. And sanitation and water in Bangladesh is very horrible, and in Malaysia it's good, but still we got some correlate association with having pneumonia. This data shows that not only clinical and bacteriological and immunological and nutritional status are really responsible for causing pneumonia. We'll have to look for these public health epidemiological parameters too. And my talk is today, it is only my objective to show you what we found. Maybe not very right. How can we make this right? And how can we make international collaborations in many countries with larger sample, with diverse geographic setup. To conclude, yes, very few prospective studies has been done with pneumonia, showing Hemophilus influenzae, does this cause or not. Plausible factors for pneumonia addressed adequately, but still those things to be added. Our finding is consistent with others worldwide that multi-drug resistant Hemophilus influenzae is one of the emerging and most important bacteria causing pneumonia. Molecular characterization should be done, which we are doing now in Malaysia. We could not do it in Bangladesh due to lack of facilities, but we have got the strengths. Maybe we'll go to ICDDR very soon. And of course, like many other studies, we have also limitation. These 2 studies was conducted 2 times, maybe 4 or 5 years apart. That might confirm our findings. Different HIV vaccination practice and protocols in 2 countries may have affected our result. Child healthcare practices can also contribute in this difference of 2 hospitals. Of course, cultural background and lab facilities may be another cause to show why Hemophilus influenzae we found more and they found less. We recommend all the GPs and rural doctors, especially in LDCs, should be trained more on WHO standard case management of childhood pneumonia, because we did a study. We found not all doctors know how to treat a pneumonia child, how to differentiate ARI, pneumonia, bronchiolitis. And we published a paper with Professor Abidus Mullah and Lutful Kabir and Nazmunar that bronchiolitis do not need antibiotics at all. It is published in Cochrane database. And culture facilities should be available in grassroots level, district, sub-district level, so that we can dig out these multi-drug resistant strains moving around the world. And this is the main thing why I'm here. I want to do some multi-center studies in Asia, Africa, Europe, for especially the Southeast Asian regional level, to see if really Hib is bye-bye and non-Hib will come or not. Thank you.
Thank you so much for the short time, but the very important data you presented. I would like to ask now if we have any questions on the paper that was presented.
Yes, please. Nobody's interested in microbiology, sir, or no. A clinician, or a pediatrician.
Do you have any questions? If not, I would like to ask a question. My question is, what is the cost of the test you did? Because it seems to be very easy to apply. It's just a swab. What is the laboratory cost of the test?
Very, very important issue, sir. Only for this, it's a very costly thing. Only for this, we could not do it properly in Bangladesh. Even in Malaysia, we cannot do it. That's why I hired some Japanese scientists to corroborate, and they are giving something. So to talk about cost, I didn't do the health economics on this and costing, but it is costly.
It's costly.
But for poor countries, only culture facilities is not very costly. But molecular biology, yes.
And the other thing I would like to point out is that you showed in the Malaysia population that Hemophilus B had probably no cases.
Very few. We didn't find any.
You didn't find
so far,
any. So that's the important message of using the Hemophilus B vaccination. It has eradicated not only pneumonia, but also meningitis from Hemophilus B that we used to see many years ago to children under the age of 4 years old, and it was a terrible disease. Also, epiglottitis from Hemophilus now is starting to be a disease that the new generation of doctors will never see.
Just one, can I please give one statement? If anybody willing to collaborate with me, you are the pediatrician, we are public health physicians and microbiologists. If we can work together, I think we can make a change positive. Thank you.
Thank you so much.